So good morning, everyone. My name is Dr. Lina Vargas. I am a board-certified vascular surgeon in Orlando, and I have the true honor of leading the EMPOWERALL webinars that are held on Saturday mornings monthly, on a monthly basis. And today I am really excited about today's topic. We're going to be talking all about perforators, indications, treatment, and we have three amazing speakers from the United States, the UK, and Turkey with us today. Perforators, we talk about superficial venous insufficiency, deep venous insufficiency, and we obviously know about the existence and the importance of these perforators, but sometimes we have clear indications for patients who obviously have advanced disease, but we know that they do play a role sometimes even in cosmetic patients or patients with not so much advanced disease. So anyways, I just feel that we don't talk about them enough, and that was one of the reasons why we wanted to have this topic today. And we have, again, three incredible vascular surgeons here to share their thoughts, their experience, their knowledge with us. So without further ado, we're going to get started with a man who obviously doesn't need any introductions, because who doesn't know Dr. Lowell Kabnick, but he is someone that I personally admire so much. He's a true pioneer, especially in the vein space. He was one of the first one to do some of the treatments that are gold standard today, endovenous ablation for treatment of truncal venous insufficiency. He has multiple patents for different devices and different treatment modalities. He's been the director of the NYU Langone program, and he's just a true educator, and he's our fearless leader. So I'm just honored to have you here today, Dr. Kabnick, to share about perforators with us today. So go ahead.
Thank you very much. I really appreciate that and that introduction. Are we sharing?
Yes.
Well, thank you very much for that lovely introduction, and I will start my presentation. Should all incompetent perforators be treated? This is not a debate, but opinions based on fact. Is there a difference between U.S. and international guidelines and beliefs that all incompetent perforators are created equal? Are we just pissing and moaning why all incompetent perforators should be treated? Or can we verify what we're saying? This editorial synthesis from the Journal of Vascular Surgery section editors followed a formal point-counterpoint between Whiteley and O'Donnell on the subject of C2 disease in incompetent perforators a decade ago. The conclusion is worth sitting with. Even in 2014, with Whiteley arguing the pro-treatment side, the editors themselves concluded the evidence did not support routine perforator treatment in C2 disease. We'll see if Mark Whiteley has changed his opinion. Assuming perforator treatment strategy means ablating perforators without significant data to establish a standard, or going beyond the standard of care, increasing the incidence without real-world data to support the necessity. Just because you can have great closure efficacy, which is a surrogate marker, doesn't mean that you have achieved the desired result. We think we know that incompetent perforators and pathologic perforators contribute to ambulatory venous hypertension. We also know that we can ablate perforators. Nikos Labropoulos in 2003 defined reflux in venous segments, particularly reflux as outward flow in the perforator is a greater than 350 milliseconds in the standing position. Others, by consensus, agreed to 500 milliseconds. In this article, it asks the question, what is the best hemodynamic measurement for incompetent perforator veins? They conclude that a lack of overlap exists between the finding of a perforator vein outward flow lasting more than 500 milliseconds and the net outward flow of the same vessel. It seems that we do not have one. What is the best method to evaluate an incompetent perforator vein? For now, we are measuring at an isolated time. In the US, we measure reflux time in a static dependent position by calf compression release. Outside the United States, some measurements are taken with a more hemodynamic measurement, the Perana maneuver, to stimulate muscle pump. Are perforators dynamic? Do perforators equalize volume and pressure in the deep system as an escape relief? Are there pressure sensors in perforators or some? As we know now, the diagnostic definition of an incompetent perforator itself is shaky before we even get to whether treatment is indicated. How important are guidelines? Guidelines are standardized evidence-based recommendations from expert panels meant to guide clinical judgment, not replace it. They are generally not mandatory, but they set a recognized standard of care built from the latest research and expert consensus. In 2014, O'Donnell and team in the management of venous leg ulcers, clinical practice guidelines with regard to perforators, they recommended the following. In C6 patients with superficial and incompetent perforator veins, with or without deep venous reflux, ablate the incompetent superficial veins first, followed by perforators and graduated compression hose. In C4B, C5, ablate the incompetent superficial veins first, followed by the perforator and graduated compression hose. Their critical observation that even in the conceded territory of C4B through C6, every recommendation is a grade 2 weak with level C, low to very low quality evidence. The field agrees treatment may be appropriate, not that it is indicated for every pathologic perforator. The new guidelines are underway and we look forward to them. What is the purpose of appropriate use criteria? To ensure that surgical procedures are performed when they are medically necessary and beneficial, helping clinicians provide safe and effective and personalized care for each patient. Let's look at appropriate use criteria, which was developed by multiple societies in the United States. The Delphi protocol was utilized. The Delphi method is a structured communication technique used to achieve consensus among a panel of experts, often in the development of appropriate use criteria in healthcare. The process typically involves multiple rounds of anonymous questionnaires to gather opinions and refine judgments, minimizing individual biases and encouraging a balanced view. This is the 2020 appropriate use criteria built by a modified Delphi panel across the SVS, AVF, American Vein Lymphatic Society, and the SIR. 2 rounds of blinded expert scoring, 1 never appropriate to 9 appropriate. An incompetent perforator over 3.5 millimeters with symptoms directed toward the affected area is appropriate to treat in C4 through C6 patients. May be appropriate in C3 and is rarely appropriate in C1 to 2, even with the same size and symptom correlation. An asymptomatic perforator in C1 or 2, regardless of size, is never appropriate. Professor Whiteley may use the 2022 European Society of Vascular Society clinical guidelines. Let's look at the wording as we go through them. Here are the actual recommendations, word for word, from the ESVS 22 guidelines. Recommendation 49 is class 3, a recommendation against, for most patients, with varicose veins and no skin changes. That is a general population being discussed, and the European Society of Vascular Surgery states do not treat. Recommendation 50 only applies to advanced skin disease, C4B through C6, and even there it is class 2B, the weakest positive recommendation grade, built on level C evidence. The American Venous Forum and the SVS published their first and second part of the venous guidelines in 2022 and 2023. Here they are. In C2 patients with axial reflux, we recommend against treatment of incompetent perforators at the same time. However, with patients that have persistent or recurrent symptoms after complete ablation, we suggest treatment if they are the origin. Remember that the quality of evidence is low to very low. What makes perforator pathological? The SVS and AVF pathological perforator definition requires all three criteria simultaneously. This is the key point where the C4B, C6 argument guideline language concedes territory, but with a strict three-part gate that most perforators will not pass. Duration alone is not enough. Size alone is not enough. Location alone is not enough. You need all three. Even with the conceded C4B, C6 territory, the appropriate use criteria and guidelines consistently require pathological criteria to be met. An incompetent perforator that does not meet the three-part definition, even in a patient with active ulceration, is not an appropriate target for treatment. This is the key message. C4B through C6 is not an automatic green light for all perforators. It is a prerequisite for considering treatment of truly pathologic perforators only. Are your surgical indications appropriate? The SVS, AVF, and AVLS uses a grade framework. Grade 1 indicates a strong recommendation, and grade 2 a weak recommendation. The European Society of Vascular Surgery uses a European Society of Cardiology framework with a class 1, 2A, 2B, and 3 recommendation categories. Despite different grading systems, the major practice conclusions are similar. Do not routinely treat perforators during initial uncomplicated C2 truncal ablation. Intervene selectively for persistent recurrent perforator-driven varices and selected advanced disease. Comparative analysis has found the overall conclusions of the two guidelines set to be comparable despite differences in methods and recommendation grading. Evidence quality for perforator-specific intervention remains limited. Where their argument applies, the physician is not never treat a perforator. It is scoped to C1 through C4 for that population. The evidence does not support routine perforator ablation. C4B, 5, and 6, advanced disease with skin changes or ulceration, are conceded territory. Even the European Society of Vascular Surgery recommendations allows treatment may be considered there, and the earlier ulcer guidelines support it, albeit at a grade 2C. Radiofrequency and ablation and laser are effective options for accessible perforators, may provide higher closure durability than foam in some series. Foam sclerotherapy is useful for tortuous, short, or difficult to cannulate perforators and can be repeated. Cyanoacrylate avoids thermal injury and tumescent anesthesia, but has limited perforator-specific comparative evidence. The trollop is a targeted ultrasound-guided thermal technique that is useful in experienced hands and is Professor Whiteley's development. Open ligation sets have largely been replaced percutaneous methods, particularly when the skin is compromised. Consider depth from the skin, proximity to nerves, and ulcer location, ability to access the vessel, prior treatment, deep system anatomy, and patient preference and operator experience. In conclusion, ladies and gentlemen, do we know enough with regards to perforator hemodynamics? Are perforator dynamic? Are they able to change flow direction depending on the status of venous pressure or volume in the system? I am against treating all incompetent perforators without more scientific evidence when it comes to perforator ablation in C1 through C4. So what should we do? Here are key takeaways. Perforator intervention should be selective and clinically driven. The main goal is to reduce clinically meaningful venous hypertension, improve symptoms, skin disease, ulcer healing, or recurrence risk, not simply to eliminate abnormal duplex finding. In C2 disease, initial truncal ablation with appropriate tributary management is generally sufficient. For persistent recurrent disease or DIC, or advanced ulcer-related disease, perforator treatment may be appropriate, and the anatomy clearly supports a casual role. Technique selection prioritize safety, feasibility, durable closure, and preservation of any necessary collateral venous pathways. Thank you very much for your attention.
Thank you, Dr. Kabnick, for that presentation. That was very, very thorough. I do have a question for you, and obviously this is clearly, what I feel and what I've seen after you presented, but I kind of want to know what your approach is. So obviously we don't have enough evidence, but I'm thinking about those that are literally in that in between. They have, let's say, I'm going to give you an example. We have someone who's C 4 with some, early changes. You do your truncal ablation of the segments that you identified being pathologic. And then, after a while, they come with recurrence, some of maybe a segment recanalized. Like I feel sometimes when I see that, usually I can find a pathologic perforator. And in theory, according to the guidelines, I don't have a strong indication to treat that. But if it's leading to potentially a segmental failure of one segment that I've treated before, like how do you approach that? What do you tell your patients? Yeah, give me your thoughts.
So originally, I would just retreat that segment, but now with some supporting literature in our 2023 guidelines, it suggests that even in C2 patients, where patients are symptomatic or you get a recurrence, you might consider treating the pathologic, the perforator. It may not be pathologic.
Right. So and here's one thing where I kind of like, debate, because I'm one of those who's like trying to educate my patients from like the get-go. So if you, and I don't do this yet, but I'm wondering if I should incorporate this into my educational part when I meet a patient for the first time. If I see on their initial scan, they say they're just C2 or C3, but they have a perforator vein. Do you even mention that? Because I've started to wonder if I should say, there's this yet additional potential vein that may pose a problem later down the line if we have a recurrence or if there's an issue. How important is that?
Well, that's a difficult question, and I have my doll here, so I'm going to pull my ears out. I think that the reality is it depends where it's located, depends upon whether you can ablate that. For example, we used to, when we did great saphenous vein, and there was a mid-thigh perforator that was incompetent, we used to treat both of them. And now the recommendation is to treat only the great saphenous vein. The other thing is that you can mention it, but in reality, the majority of incompetent perforators along a truncal vein usually disappear after you've treated that. And then the last thing that I'll talk about and allude to it is the deep venous obstruction. And if you have a patient with deep venous obstruction and you have C5, C6 disease, which one do you treat first? So in my opinion, it really depends on what we're looking at and the degree of obstruction. So for me, obstruction is probably pretty more important than the limited reflux that you get with truncal veins or an incompetent perforator. But that doesn't mean that you're not going to treat all three of them with C5 and C6 disease. It's just the question of priority in which you treat. And then as you come back to see what happens to that incompetent perforator, if they're still existing, 100% would treat. And so the idea of mentioning in the future, I think, is important, that we identify an incompetent perforator, what that means to them, connecting the deep to the superficial, and it may give you issues. And that's why it's important to follow up, which most patients at a year do not.
Yeah, I think that's key. I just feel sometimes we end up, there's so much, especially when you're meeting a patient for the first time, there's so much information to go over, but at the same time, like I do want to try to, well, first of all, making an emphasis, even if there's no perforators, that venous insufficiency is a chronic condition and it's never, we're just going to treat, one time and we're done, especially when there's perforators. So, but it happens, I guess, more in a staged fashion where you're, every time just really explaining, what this pathology is, how this behaves, and the chronicity of it. So you're setting right expectations and going back to the point as far as like what you're treating first and second, and obviously, hopefully not everything at the same time, just saying, you're going, you're never going to be 100% certain about what's really the main driver, but you definitely always have clues on your exam and your ultrasound that guide you towards what may be the most significant thing. So thank you for that.
It's very interesting about the facts of perforators, and I know Whiteley has done a fair amount of research on this, and I look forward to his presentation on it going forward.
Before we move
Yes.
forward, there's a question from Dr. Navas on the chat. Dr. Navas is a dear friend of us, so I'm so happy to see you here. He's wondering, this is his question. Do you inform your patients that you will treat their saphenous reflux and leave any insufficient perforating veins and treat it to see what happens? Kind of going back to that.
So I treat the truncal veins first and then see what happens to the incompetent perforator, because in theory, in studies, most of those incompetent perforators along the truncal veins do disappear.
Okay, thank you. All right, well, Rebecca, go ahead and
Yes.
Yeah.
Thank you. I'm so happy to have you all here. I'm going to present Dr. Mark Whiteley. He's the founder of the College of Phlebology, and he is a consultant venous surgeon, and he lives in UK, and he has more than 30 years of work, minimally invasive treatment for all the venous pathologies. And he is the first one to perform the first endovenous thermal ablation in UK, and the first endovenous perforator closer in the world. So we are so happy and so excited to listen to you, Dr. Mark.
Thank you very much, Rebecca. That's very kind of you. So thank you very much. I personally, so we're talking about perforators under pressure, obviously indications. These are my disclosures. Just talking a little bit of what you've just heard about, I actually think that the guidelines are premature. And one of the reasons the guidelines are premature is, as you've just heard very eloquently from Lowell, we don't really know the criteria of what is a pathological perforator and what isn't. And so therefore, writing guidelines about something which we don't even have a clear definition seems a ridiculous thing, apart from for people to say, here are some guidelines. And I think it's very important that they're not mandatory, because I think they're not very it's not a sensible thing until you've got really good, clear guidelines, a good criteria rather, as what constitutes a pathological perforator. I think its position, not only its size, but where it's actually coming from and to are important, and what associated pathology or lack of pathology is also very important. And as such, the very most important thing is, of course, they're misunderstood. They do take a long time to find on duplex scanning, and an awful lot of people who talk about them don't actually actively look for them. And we know this certainly in the UK. There was recently a ultrasound conference where the vascular technologists from one area of England revealed that they were told by their consultants not to report incompetent perforators, because they didn't want to be explained to patients that they didn't know how to treat them or whether they should or not. So the difficulty with studies and everything, I think this is where we get from academia, where we're trying to find the answers, and what Lowell quite rightly calls is real world experience. We know the two are absolutely, totally different. But what we're trying to do in life is, certainly those of us leading, are trying to find out what we should do and then bring everyone else along with us. And it does take a lot of training to both find them and treat them. And there's this great incentive for doctors just say they don't matter, because that way you can ignore them. But what we're trying to do with our patients is we're trying to give them a good result that they're happy with. And I personally don't like doing something and then saying to patients, we'll see and put you through a second or third or fourth operation, which puts them through risks and also expense. You heard from Lowell that a lot of perforators disappear when you treat the reflux above them, or the truncal reflux. That's actually been shown to be erroneous if you then do the long-term follow-ups. So if you actually do long-term follow-ups, these papers show short-term follow-ups. When you actually do the long-term follow-ups, like we published, you actually find that 82% actually reappear within a year. So the short-term apparent closure quite often is either a quick hemodynamic change or more likely a thrombosis, which then opens up. But this is the sort of patient I see, and luckily it keeps me in practice, because these patients come and see me from far and wide. This typical patient, the history is she's got C4, as you can see, particularly on the left-hand side, and she's about to bleed. She's got the very, very fine, it doesn't quite show so well, but on this left shin, they're very thin-walled veins, very close to the surface. And as usual, certainly in the UK, she's had stripping first, then she's had endovenous ablation elsewhere for bits of truncal veins, had phlebectomies, had foam sclerotherapy, and every single bit has been aimed at, goodness gracious, has the great venous vein, small venous vein come back, and it's all truncal veins and phlebectomies, and nobody's assessed or even looked or mentioned to her about perforators. This is what we're starting to look at more and more is infrared thermography, and we're doing a lot of work on this. And as you can see, just like in the great venous vein and small venous vein, what we're trying to look at in superficial venous disease is the egression of blood from the deep system to the superficial system. And we all agree if it comes through your saphenofemoral junction, it's important. And if it comes from your saphenopopsioid junction, it's important. But for some reason, when it comes from any other route, you're now trying to say it's not important. Whereas the fact is it's a similar pathophysiology, although in the below knee perforator, it tends to be at a much higher velocity and causing more inflammation. And above knee perforator, a lower velocity, but as the weight of the reflux. So this patient, when we scanned her, of course, she's had her truncal veins treated. The anterior accessory venous vein on the left side there is only very small, it's 2 millimeters, and her major recurrence is from untreated previous perforators. Lowell's already explained about the transatlantic debate, and at that stage I sort of said really my view is if you accept that perforators are associated with the latter stages of venous incompetence and inflammatory disease secondary to venous incompetence stasis, it seems intolerable to not accept that they're also associated at the early stages. I mean, all we're looking at is a time factor. If you have reflux that is causing problems in later stages, then of course that reflux was what was causing it in the early stages. So it just seems to be very weird that people would say treat perforators as C6 or C5 because we've got good randomized controlled evidence, but suddenly they're not important until you have got that, you progress to C5. We know that that's the cause of the progression. And we've shown that it's a major factor of recurrent varicose veins, not only our work, but elsewhere. So we now know that if you do leave all incompetent perforating veins, you will have a much higher chance of recurrence. This is work that's been unpublished at the moment, although it's just submitting it at present, just purely and simply 22,000 legs. My colleague Barry Price has been following these patients up for years and shown that when you just look at severity of disease at presentation, there's an increase that increases with the number of incompetent perforators. So there's a clear association that perforators in their own right are associated, maybe not causative this, but associated with a deterioration of clinical degrading at presentation. We also know that there's the books of the hemodynamic surgeons that tend to try to persuade us that this idea that perforators don't reflux because of it's not a pressure, it's a flow phenomenon. We know that's not actually true, and what we have found is when you actually have the muscular contraction, you get your outward flow. And one of the difficulties is as Lowell said, the Prana technique is a much better way of measuring these incompetent perforators because you're getting a proper muscle contraction, which is what you see in real life when they're having a problem. Whereas, of course, if you're doing manual calf compression, it depends where you're pushing, and so therefore you're not necessarily seeing reflux. And I think this is the whole argument of 0.35 versus 0.5 seconds reflux is ridiculous, because what we're actually trying to look at is it making a pathological difference, and just trying to get criteria on duplex doesn't correlate at the moment to what the perforator damage is causing. So there's a lot of work that needs to be done on this. This is just a patient I presented a couple of times before. All she's got a tender varicosity over the front of her tibia. She's got no truncal reflux, nothing else. And we can see it very, very clearly that the only source of reflux into this tender area is in one single incompetent perforator. When she stands up, she gets immediate hot spot, which means blood is leaking from her deep system to her superficial system, but this settles down with time. So this is a clear reflux shown by infrared thermography when she stands and then stands still. But more importantly, this is dynamic. She's lying down here, so there's no gravity at all. But as she constricts her muscle by doing dorsiflexion, you can see the blood starting to appear. This is on infrared thermography. The heat of the blood coming from the deep system shows us a yellow-orange heating area. And this is absolute clear indication that this is an active reflux, or what some people call systolic reflux. It is not a passive reflux. And so therefore, we have to really change the whole of our criteria of how we measure these if we're going to start understanding incompetent perforating veins. When it comes to treatment, you've heard Lowell's done a very good analysis, which I totally agree with. My personal view is you should only ever use an ablative method such as the trollop, and you should close it actually at the fascial level. You can use any thermal ablation for this. Foam sclerotherapy, you're not going to ever effectively close these perforators because they're high pressure, thick walled vessels. And you'll close the vessels above them maybe, but if you're going to get enough sclerosant into the perforator to actually cause a closure, you're going to also end up with a large number of DVTs or DVSs in the lower leg. So I think it's totally inappropriate. The big question is whether glue can be used for these without getting your PLA and your reaction. So in sort of conclusion, I keep away from the guidelines because I just think they're rubbish. I think they basically are backward looking on bad research and don't really use scientific thought processes. But we know that incompetent perforators, everybody agrees, they're associated with clinical worsening stages. We know they reflux on movement, they're an active reflux as well as some passive reflux. We know that they're found in relation to C2 and C1 disease. We see it all the time in recurrence. We know that the failure to treat them is a major cause of recurrence. And therefore, at the moment, I can't turn around and say we have to treat all perforators because we don't have the criteria of what they are. And so therefore, when you have reports say there's 12 incompetent perforators, we can't be absolutely certain there are 12 incompetent perforators because nobody can actually give an absolute definition of which ones are or not. So it's an impression that this looks like it's incompetent is the best we can do at the moment. But if it's associated with a direct pathology, either varicosities, thread veins, or something that's clearly associated with that perforator, I think you're probably negligent not to treat it in the best way possible. And certainly for my patients would like to come in, have their problem treated and go away, and not come in, have the problem treated and then wait 4 or 5 weeks and then another treatment, another treatment, another treatment. So therefore, my criteria would be if you've got what looks like an incompetent perforator and it's associated with some pathology that the patient wants to get rid of or needs to get rid of, then you should treat it. Thank you.
Great, Dr. Mark. Thank you so much. Lina?
So I just wanted to let everyone know that Dr. Boskert unfortunately will not be able to join because he's dealing with a ruptured AAA in the OR as we speak. And so we wish him luck with that case. So, we won't have his part of the presentation, unfortunately, but that I think will leave a lot more time for discussion, which is actually a good thing because I have a bunch of questions and I know you guys do too. So Rebecca, I know you had some things to ask.
Yes, I have a question about first of all, I know it takes time to find the perforator. It takes time to train to see them. We have a map of perforators right now, the most common. And I want to ask you, who performed the ultrasound? By yourself, Dr. Kabnick, or somebody else is the one who is doing the ultrasound?
So in the US, typically it's performed by a technician, sonographer. However, most of us will pick up our own ultrasound probe, especially looking at complex disease. And so I personally do pick up my own probe. I do look at incompetent perforators, and we all do look at them when it comes time for treatment.
Okay, thank you. And Dr. Mark, do you perform the ultrasound, or somebody else make you the map of the perforators?
No, we're very fortunate. We have some very excellent vascular technologists. So it's mainly done by vascular technologists. However, with the new research we're doing on the infrared thermography, what happens is we quite often will check with the infrared thermography and then go back again and say, you know, is this incompetent perforator? Have you missed one? What's causing this image? So we're sort of trying to tease out those ones that we can see that are clearly causing a problem. If they're not reported on the first report, we go back to see if there's another cause or whether it's an incompetent perforator. So in the normal clinical situation, yes, it's just the vascular technologist, but more and more on the research side now, it's a combination of my researchers doing the infrared thermography as well, and then a redo scan if needed.
If I can interject, Mark, I am really interested in thermography as an aid. We are also doing some investigative work with that, Dale Maharaj and myself, and we're looking at all sorts of different ideas with that. Yes, one of them is certainly perforators, and they're really, they I think are an aid, they're not a substitute. And the question is, looking at that, it is a qualitative, but not quantitative when we look at thermography at this point. And then the question whether we can go from a recumbent position to a standing position, and what the time it takes to look at that, and then again the time it disappears, and if we can relate that to any incompetence or pathology with an incompetent perforator. We should talk offline about this. I find it fascinating.
Yeah. We've just presented a paper in Versailles, actually, exactly on when to look for incompetence, and it varies so much. And I think also one thing that we can say, you know, obviously it's a research interest for both of us, but one thing that's very clear is with thermography, you have a depth problem. So if you have a very large leg, you're just not going to see reflux, even though you can see it might be under lipodermatosclerosis. Whereas if you have a very skinny leg, you know, you sort of see everything that's refluxing. So it's an aid. You're quite right, but it's not going to be a gold standard.
There are some downsides to thermography. But that being said, I did enjoy your the presentation at the European Venous Forum in Versailles.
Thank you. Yeah.
When you both have that conversation offline, can you please record it so that we can all learn from what two super bright minds talk about offline? Like I would love to be a fly on the wall while you both are having that conversation. But I thought, you know, Mark, that thermography patient that you showed, I thought that was so interesting because, I mean, that patient, I mean, aren't we telling our patients that to do calf pumps and exercise, and that's actually in that patient what's, you know, feeding into that perforator. So that was very, very interesting to see. I've seen I don't have a lot of experience with thermography, but I definitely feel that there is a role for it, you know, maybe not so much for everyone, and you know, everyone's setups are different because of the time it takes, but I do feel that it may help us answer some questions about what is more important in certain patients, and do we need to look deeper in certain patients as well. So I thought that was very, very interesting. So Dr. Kabnick, I have a question for you. So obviously it's very clear, you know, regardless of what the treatment modalities we have, it's clear to me what Dr. Whiteley, what's his preference. But for you, you mentioned obviously all of these things. What is your go-to? Ignore the guidelines, ignore everything else. What is your go-to? How do you treat perforators in your practice?
So it really depends on type of perforator, where it is. But
okay.
The majority of mine is thermal ablation, and the majority of what I use is laser.
Okay.
You know, depending upon where it is, what's going on, I could use other devices. I've actually witnessed and seen Professor Bosker do ablation using cyanoacrylate of perforators, and it seems like a very easy procedure to do. And I know that it's starting to be investigated here in the US as well.
And for you, Mark, is it RF? Is it laser? What's your preference?
Yeah, we started off with radio frequency right back in the day, and then went to RFITT, and then ended up with laser. At the moment, we put like a single ring radio laser because you can be absolutely precise where you're doing it. We've done, about 200,000 individual perforators, and we've had, I think, one AV malformation, AV fistula afterwards, and a couple of sort of transient neuropraxies. It's quite an uncommon. Actually, I'm just about to report our first ever false aneurysm from one, but
Oh,
that's
wow.
after 25 years of doing them.
That's a
So
lot.
we like doing that. I would love to do one of my other presentations I give, which really is pertinent to this, is about Klippel-Trenaunay syndrome, because of course that is, although everyone talks about the different criteria, it is a perforator vein problem. That's what we all know. They come to you, they've got 30 or 40 perforators, they're 5 millimeters, 6 millimeters, and I would love to do those with glue. But I just have a worry still about doing glue with so much, because if they do get a reaction to it, we know reactions are quite uncommon. Minor reactions, 1 in 5, but there are reactions, and I just still have a concern about that. But I would love to do, having seen some of the work, and it's a shame Dr. Boscott, Professor Boscott, isn't doing it, because I've seen some of his videos, and it would make my life a lot easier for those sorts of patients with huge perforators to use glue. But I'm just still a bit nervous. So at the moment, for me, it's a single ring radial laser.
Mark, you isolated KTS, and we know that those patients can be hypercoagulable, and any perforator treatment there is worrisome. And the fact of the inflammatory response that you get with cyanoacrylate in those particular patients, it would be interesting to see what their natural history is. Mark, you quoted a number here of 200,000 perforators. That's amazing. So obviously your indications for more than C4B, 5, and 6 are there. I figured that out to be about 4,000 perforators a year. Can you comment on that? I know you have
Yeah.
people, you
So
have
so
many patients and you have many locations and you have many physicians, but uh,
Yeah, basically it's rare to find a patient that doesn't have a significant perforator somewhere in their tract, and we get an awful lot of people who have had 5, 6, 7 operations, and they come to us for expertise, and they'll have the sort of 9 or 10 perforators like that lady I showed you. Our latest figures, because of our reputation, we tend to get half of our patients come to us because they've had a recurrent patients. So we have a slightly skewed, well, quite skewed population in one way, and so I think we have a lot of patients, more and more patients with either KTS or sort of people you can't put down as KTS, but clearly are on that spectrum towards that, which is something I'm quite interested in at the moment. So I would suspect that we probably are treating on average, if you averaged across everyone, probably 3 or 4 perforators per patient. Some obviously have none, but some have 30. And so, it is difficult, but we don't have a normal population coming to see us anymore, because a lot of our patients are recurrences.
it's kind of interesting that there are over 150 perforators in a leg last count. And I would say that Lina's probably experienced this. Sometimes when we have to submit for approval for our patients. And if we are starting to increase our perforator population, there's a whole lot of pushback. And so I'm looking forward to more of your publications, Mark, to help us out with the fact that we can't cure venous disease, but we can certainly control it. And I know
Yeah.
that you did have I think a publication on this early on about perforators. I think there was a handbook of some sort.
Yeah, done quite a few. We've put the Barry Price has just done some amazing work,
Oh, I
and
didn't
I
know
think
that.
one of his we put up on a preprint server. Also about where these perforators occur, because the traditional idea of calling them names is absolutely ridiculous. Because when you actually put thousands and thousands and thousands into a map, it just you find it's a cloud, and they come out where the muscles, either through the muscle in one specific area or down the edges of the muscles. And he's identified the 4 sort of main locations. But Barry's work is quite quite remarkable. It's just we're trying to get all of that out this summer, and hopefully that will help.
Well, it's incredible to listen to you both. I don't want to interrupt you, but I have a question. I know that most of the people, they are thinking that maybe the perforators are not important until they appear on the map. So, could you give me an advice to understand the venous reflux? Because I know that we are going to discover more information about perforators, veins, as the times goes on. So for all the people who are listening to us, and even for me, do you have any advice? How can I understand, even that I do my own, I do my own ultrasound here in my office. And yeah, I have any doubt, I have some interventional radiologists or radiologists who are making my map of the perforators. But do you have any advice to understand a little bit more about it? Because I know that in here, this is a webinar to listen to experts and to understand what we are treating the perforators, please.
I would say that we're very fortunate because we have vascular technologists. But my own view is, if I was doing my own scan, the most important place, you obviously don't want to scan the whole of the leg if you can possibly do it. But if you have a pathological area, so you have a large varicosity, or you have lipodermatosclerosis, or you have a really big patch of thread veins, then look at that and trace it back to its origin. And that's when you'll often find your large incompetent perforator feeding into those. The big one, of course, and one of the things we've talked about before, I think I've talked to Lowell about this before, is there's clearly a difference. There's at least 3 different sorts of perforators. So you've got below-knee incompetent perforators, which jet out high-pressure blood when you contract your calf, and we see that a lot in cyclists in particular. You've got your above-knee perforators, which are basically passive reflux. They're almost like another great saphenous vein with an incompetent valve at the top, and they reflux because of gravity. But we've also got this interesting perforator, the perforator of the popliteal fossa, which is coming out through the popliteal fossa and is often missed when people will strip or endovenous laser or radiofrequency the small saphenous vein and completely miss the fact it's a huge perforator coming out. And that perforator is incredibly difficult to treat because it's large, it's floppy, it's got nothing around it. And when you use the trollop technique, you have to be very, very careful because of the local nerves, and you have to pulse the energy and not use these sort of things where they say 1 minute of the heating north, 1 minute south, 1 minute east, 1 minute west, which was the RFSS thing. And there's actually been a big court case in Australia where someone got foot drop doing that. You have to be very careful. And you have to also close about 2 to 3 centimeters, not just at the fascia. So, as far as the pathophysiology and the flow of that, it looks more like a passive reflux on standing, like a small sphinx. So at the moment, as Lowell said quite rightly, I think that the difficulty with this is we haven't identified the true criteria of a pathological perforator. And particularly, when you have people talking about it and they don't even set them up into different areas of the leg, that it's very superficial conversation we're having at the moment. And we really need to drill down and get some good sort of quantification and some good ideas so that we can know what we're talking. Then we're comparing apples with apples and pears with pears.
I wonder if we're really going to ever get to that point, because the problem is perforators are like so different. Like, they're so different. GSDs, SSDs are all about the same, but I mean, even on one single patient, like they're so different. Like you're saying, the localization, their pathophysiology, whether sometimes they are literally going straight down, sometimes they take a nice curve and winding road, and I mean, I think all of those things definitely play a role. And they're just so different that I think it's almost impossible to think that we're ever going to be comparing apples to apples, I think, which is frustrating.
And I think also another thing that Laura said earlier, which is really important, is what we're talking about at the moment is we're talking about simple perforators and we're assuming the deep veins are normal in all of these patients because we're just talking about perforators. But as Laura said, of course, we see these in people with post-thrombotic syndrome, NIVL, and all sorts of things. And that's then a completely different story again. You can't use the same criteria at all for those perforators because they're probably performing a different function. And so, this really has to be teased out if we can ever do it.
I would like to interject here. Let's face it, we know very little about perforators. There's very little that we know. I do believe that they're dynamic. I do believe that there's probably some type of flow sensors or volume sensors. I do believe that what we're measuring at a particular time is not always going to be the same as we see certainly in truncal reflux. So I think we need a combination of more probably technology to understand what we're doing and looking at dynamics as opposed to one and done. At least the Piranha maneuver simulates a physiological exercise. The compression release to me is probably not the best method for perforators. And I do believe that they change over time until they're really broken.
Yeah.
Mark, do you believe that perforators have valves?
We can see the valves on ultrasound. Yeah.
Absolutely.
So, yeah.
So
And I find it ridiculous when you stand up and people still say they don't because you can actually see them there. I'll tell you one thing that's interesting. I don't know if you've seen Luca Palomi's work from Venice, but he's got one of these small ultrasound machines and it's got a brace that puts it right over the veins he's investigating and getting people to walk. And the one problem with that, of course, the trouble with it, of course, is the actual things that are holding it alter the hemodynamics. But it's the starting of some very clever ideas, and I really think that he's a bright young man coming through. And I think that's the sort of thing we should be looking at, is something that's wearable to see what the true function of the perforator, as you said, to get to the bottom of the pathophysiology of it.
Totally agree, and really believe that Luca is an up-and-coming star, or actually is a star. It's not up and
He is,
coming.
So we definitely have two rock stars here. And so if, understanding our limitations and our paucity of data, like what would you say today if you could change like the guidelines with what we have, very limited information? What would be the indication for you? Like if you could come up with a guideline today, like how would you change that reflux time, all of that? Like what would be your guideline today?
Do you want to go first, Lowell, or shall I?
And I'll follow.
All right. My guideline is just as I said at the end of my talk. If a perforator is associated with a pathological problem that the patient wants treated or you want to treat, you should treat it. So in other words, if it's under LDS, if it's under an ulcer, absolutely everyone would agree. If it's under a varicose vein that is associated with that perforator, and not just it's not happens to be found under truncal reflux, but it is going into the thing, it probably needs treatment. Right the way down to C1. If you have a great big patch of thread veins, particularly if they've been treated previously and they keep coming back again, and what you find, and as if you find a perforator to go directly into them, you really need to treat it if you're going to give that patient the result they want. So my thing would be a clinical guideline, not something that we make up with ultrasound.
Mark, you should have seen Dr. Kabnick's eyebrows go like all the way
Oh,
up
I did.
here.
I saw them.
Did you see that?
Even
I recommend
the
that you guys go watch the recording when we post this, because his eyebrows gone all the way up here. I was like, oh my gosh.
Lina, what was even better is that on my screen, he's only a very small thing, and I even saw his movement even on that tiny screen.
Mark,
Yeah, so
I'm glad that you have not changed in your philosophy, and that's been pretty static. I'm not totally disagreeing with you, but let's talk about clinically warranted patients as opposed to aesthetic patients. Aesthetic patients are a different thing. So for me, a patient needs to have symptoms, and not just the fact that they have varicose veins, but required. So I don't believe that any of us disagree with C4B, 5, and 6 in terms of perforators. The pathological criteria, I'm not sure that that's going to prevail in the future. It'd be interesting to see what happens in our next generation of interventional venous physicians. With the fact that you are very aggressive, and I don't fault you for that, especially when it comes to aesthetics, I think that you're onto something. The question is whether you take out, and we're looking at this as well, if you have a patient that has C6 disease and superficial truncal, as well as deep venous obstruction, which one do you treat first and why? Well, we all know what we've been taught, but if you treat the end result first and then go forwards, in other words, if you have an incompetent perforator and you have underlying venous plexus under the ulcer, why not treat those first? Why not treat the perforator first? Because that's the end organ, is the ulcer in the skin, and then work backwards. If you leave those alone and not do anything further, then I think what you're saying, based on some other things that you said you're going to get a recurrence faster. But we know that what perforators do is they decrease the recurrence rate, and they also keep ulcers healed, and that's at the end of the game. So it might be interesting to start the other way around. And then skin ulcers really depend on the patient, because we know that patients that have the same underlying problem, deep venous, superficial, perforators, venous plexus, may not develop an ulcer, or some do. So I think the end organ of skin really is different in the amount of inflammation that occurs. So there's a whole lot of stuff that we need to learn in terms of venous pathophysiology. Well, thank you for allowing me to share my eyebrows.
Yeah, never get Botox, please. Like we want to see those expressions come through every single time, like, you know. But anyways, one final quick question. We literally have 3 minutes, and I would much rather spend them asking one final question instead of, like, you know, saying goodbye to everyone. So I'm in the United States, so I understand what the indications from an insurance standpoint are. But like for you and internationally, how do you go about treating them, like with insurance? How does that look like, Mark, over in the UK? Like how are you getting these patients treated?
So we're very, very fortunate, and I was about to bring that up if we had more time, but with what Lowell said, because I think the thing with it is we've been free. I left the NHS some time ago because the NHS in the UK does not want veins to be treated. They really trying to get through the NHS is almost impossible. The insurance companies are all turning their backs on veins and making it very, very difficult. And so I'm completely free because I don't work with any insurance companies now. My clinics only work with self-pay. And that's been, but in some ways it's been forced on us, but in fact it's made the playing field flat, which is great, because then patients choose the doctors, they get the best results, or they choose on price, and they can decide, because the two don't correlate. I think that's one of the things that I think sometimes when we talk internationally, we do talk at cross purposes, because my view is if a patient comes to see me and they've got a clinical problem, obviously I treat the clinical problem. If they come treat an aesthetic problem, I treat aesthetic problem. So I think aesthetic phlebology is growing massively in my clinic, and we've published quite a few papers now on mini endovenous laser of the forehead, and we've just done a micro EVLA of the faces. And those aren't clinical problems, but they're severe aesthetic problems when people are affected. And so it comes down to very much, we're serving our patients. Because we don't have to serve our paymasters, because we don't have paymasters. Our paymasters are our patients. So when a patient comes to us, we're going to try and give them what they want. And if it's a medical problem they've got, we'll treat them medically. If it's an aesthetic problem, we'll treat them aesthetically.
Mark,
Well, thank you for...
I totally, hold on a second, Lina. I totally agree with you. I started off as an aesthetic vascular surgeon and opened up a clinic for sclerotherapy in 1986, and I never accepted insurance in that part. As well as moving forward, I dropped insurance until I went to New York University. But it's an interesting thing. Who governs our regulations? And why are they governing our regulations, especially in the insurance companies? And who dictates to them? And even if we come out with guidelines, they kind of say it's still experimental and investigational, et cetera, in the US. So I completely agree with you along that. And that's why I think consensus opinions are just as good sometimes as we look at guidelines, because guidelines sometimes are made by a group of people that have consensus, but it's not necessarily real world data. And it's based on RCTs, which also have limitations in terms of real world data. But thank you for sharing the fact that you're completely at a network. I believe that there are people in the United States that are gravitating toward that because we're being harmed sometimes by our governance. So thank you for that.
Yeah, I echo that. I that's literally, when I woke up every morning and I'm looking at my goal in the future is to drop insurance altogether. I'm not there yet. Obviously, I'm building my practice towards that because I find it absolutely ridiculous that, we get denials even for things that are, indication is clear as day, and it's incredible that our patients cannot get the treatment that they want. So that's my goal, and like Lowell said, that's the future for many private practices in the US moving forward, which I think is going to be great for patients.
I can help you with that strategy because I've faced it. So it's relatively simple to do. When I first started out, I lost 20% volume.
Yeah, that's my thing. It's like I'm not ready to take that hit yet. And like there's no way I can do that, but ultimately that's where we're going. And actually, just the ever-changing environment of insurances are doing that for us. Like I'm gonna give you just a quick example. Here in Florida, there's an insurance company that does not cover any vein treatments at all, even for someone with a venous ulcer. They won't. And so while some practices here in Florida have stopped taking that insurance, I've continued it, but then because those patients still need treatment. So those patients were having that self-pay conversation and we're getting really good at it, which is, it's good for the patients. And so that's where we're headed.
To be clear, I lost 20% of volume, and that's what forced me into spending time in research. But shortly thereafter, there's methodologies of which you can overcome that. And that's really discussion with patients. So I think it's people are moving in that direction. The problem in the United States is private equity. And I won't discuss that. We will have another topic on that.
Yeah, we're definitely planning a future webinar on this, and maybe we'll have you there, Mark, to kind of help us and give us some guidance as to how we do that. So I suspect I'm going to have you back for that because it's definitely a topic that we need to talk about. But we've gone over the end, of the time, and I want to thank both of you for being here. I mean, you're both absolutely amazing, and we're just so incredibly lucky to have you both here. It's unfortunate that Dr. Boskert couldn't join, but thank you everyone for spending some time with us this morning learning. If you have any further questions, please send them our way. We'll be happy to answer them, and we'll be sending information about our next webinar for September. Thank you, everyone. Thank you, Rebecca, for being my partner in crime, and everyone for being here. Thank you.
Thank you.
Thank you so much. So nice. Have
Bye.
a good Saturday.
You too.
Bye.
Thank you, Mark.
Cheers. See you, Lowell.